Welcome to this module on billing for palliative care services in Ontario for primary care physicians. My name is Dr. Bob Sauls. I have worked in both family practice and full-time palliative care practice. This module has been developed in collaboration with the Capacity Project, which is working to develop the capacity of primary care physicians to provide palliative care for their patients. I will take you through a case-based approach to billing for those palliative care services that you provide for your patients in a variety of settings. The objectives for this module will be to, first, identify who among your patients are eligible for palliative care fee codes. Next, I want to highlight the key fee codes that you will use in day-to-day practice and talk about how you would use them in the office, a patient's home, in a hospital, or in a long-term care home. Finally, while the fee-for-service codes are entirely relevant for physicians working in patient enrollment models, such as family health organizations and family health networks, I want to identify some of the issues specific to those models. Before we start, there are a few things to highlight about this module. The information in this module is based on the current version of the OHIP Schedule of Benefits published on the Ministry of Health and Long-Term Care website. This is current as of November 2018. There is also a valuable summary of palliative care billing that has been developed by the Ontario Medical Association. To access that document, you will need to log into your OMA account and locate it under the menu items listed here. The module will take about 30 to 40 minutes to complete. To replay any of the audio segments, you can simply click on the speaker icon in the lower right-hand corner. As a final reminder, you are able to claim study credits with the College of Family Physicians of Canada as a Main Pro non-certified activity. Let's talk about Joseph. He's a 78-year-old man who, along with his wife, has been in your practice for many years. He has been a smoker and has had long-standing hypertension. For years, he has suffered 2 myocardial infarctions, and in the last several years has developed heart failure. In the last 6 months, his heart failure has worsened. He's had 3 admissions to hospital, and his improvement after each admission has been limited. He is now short of breath with most activity, and for the most part is confined to a chair or bed. He's coming to see you following his most recent admission to hospital. So, is Joseph in need of palliative care? Are you able to use palliative care fee codes for Joseph's care? As we consider whether Joseph's care is eligible for palliative care fee codes, we can look at 2 sets of criteria for making that decision. The first is the OHIP definition of palliative care, and the second is the current approach to early identification of patients who would benefit from palliative care. Let's look at these 2 different perspectives. What you see here is the definition of palliative care found in the OHIP Schedule of Benefits. This may leave you with some questions. For example, how accurately can we predict prognosis, especially with non-cancer illnesses? Or what constitutes aggressive treatment that might disallow use of palliative care fee codes? The current literature on palliative care has shown that earlier identification of patients with palliative care needs results in better outcomes. These outcomes include better quality of life, less time spent in hospital, and a higher likelihood of people dying in the place of their choosing. The link included here will take you to a listing of and links to tools to assist you with early identification of patients with palliative care needs. When we compare this early identification approach with the OHIP definition, you may wonder about cancer patients who are still receiving chemotherapy, or patients like Joseph, whose prognosis is less predictable, or patients whose prognosis will likely be longer than 1 year. In combining definitions, the key will be to document your decision to use palliative care fee codes and why your patient's care is eligible for these codes. This would include documenting a declining functional status, increasing symptoms, or evidence of disease progression despite treatment. Documenting evidence of advanced illness with progression rather than simply a diagnosis would be the best way to achieve a balance between the OHIP definition relative to prognosis and good palliative care practice. The other element to document is the intention of any specific treatment that the patient may be receiving. For example, patients with a progressive cancer may be receiving palliative chemotherapy, that is, chemotherapy not directed toward cure, but rather toward some degree of life prolongation or maintenance of quality of life. Similarly, good disease management of heart failure, renal failure, or COPD is aimed at providing patients with improved quality of life as best as that is possible. Even where a patient may have an unrealistic expectation of the outcome of treatments, documentation of the treatment intent and expected outcome will support your use of palliative care fee codes. Finally, the other element that is part of good practice to justify the use of these codes is a conversation with the patient about his or her goals of care. This would include a discussion about their understanding of their condition and the options for treatment and care, as well as their goals for that care. If we return to Joseph, it's quite clear he's in need of palliative care. He has clear evidence of disease progression with increasing refractoriness to treatment. He is noticeably short of breath at rest and spends most of his day in bed with occasional periods up in a chair. So the answer to our question is yes, his care is eligible for palliative care fee codes. After a brief initial visit, recognizing Joseph's need for palliative care, you arrange to meet with Joseph and his wife in your office to talk in more detail about his care needs. During that visit that lasts 50 minutes, you explore his illness. It is apparent that Joseph and his wife understand that he is declining and will die in the foreseeable future. Based on this, you have a discussion with them about his values and preferences and goals for his care. You assess his symptoms and functional limitations at home and agree on a plan for making a referral of home care to address some of those needs. Finally, you outline for Joseph and his wife that you will be providing his ongoing care with input from his cardiologist and discuss how to access care when he needs it. So, how would you bill for Joseph's care at this point? Which code or codes would you use? The most frequently used code for this visit is titled Palliative Care Support. This is a time-based service billed in units to be used when you provide one or more of the elements of palliative care during that visit. You can bill K023 when you have spent a minimum of 20 minutes with the patient. Additional units can be billed when you have spent 30 minutes and then 20 minutes of the next half hour. It is a requirement that you record both the start and stop times of the visit. The K023 code can be used in any setting where you provide palliative care, the office, a hospital, in a patient's home, or a long-term care home, as long as it meets the service and time requirements. Again, ensure that you document the times and the service you have provided. So for Joseph, you would bill 2 units of K023 for this visit because you spent a total of 50 minutes with him. But there's another fee code to consider for Joseph's care. The Palliative Care Case Management Fee Code is another frequently used code. The services which this code encompasses include ordering and interpreting tests, coordinating and communicating with home care and other community services, arranging other assessments or treatments, and telephone conversations with the patient, family, or substitute decision maker. While using this code, physicians would continue to bill for billable services such as K023 or home visits. The G512 code is billed weekly, with the week commencing at midnight on Sunday. During the first encounter with the patient for palliative care, the code can be billed starting at any time that week. While the definitions of this code do not explicitly place a time limit on how long the code can be used, the physician is referred back to the definition of palliative care, which identifies the final year of life. As discussed earlier, good documentation of the patient's status can support use of the code for longer periods where that is appropriate. The G512 code can only be billed by the physician who is most responsible for the palliative care of that patient. Where there are multiple physicians providing care, it may be valuable to ask, who will be the first one to be called with concerns about the patient's care? In these instances, it may be necessary for physicians to come to an agreement as to who will be billing G512 for that patient. In instances where one physician covers for another for part of a week, the physician who is responsible for the majority of the week should bill G512. As with the K023 code, the G512 can be used in any care setting. There are several billing codes that are associated with home care services. The first is the code for the initial application for home care services, K070. While this is not specific to palliative care, it would be applicable to Joseph's care. It is important to note that to be eligible, this referral needs to be completed by the physician or a person employed by the physician. For example, one could not bill for this service if the referral was completed by hospital staff and simply signed by the physician. You may be aware that there are fee codes for weekly home care supervision, K071 and K072. However, when billing G512, these services are considered part of that service and are not separately billable. So, to summarize, the billing for Joseph for this visit will be 2 units of K023 for this visit, G512 for the first week, and K070 for the home care application. The total for this billing will be $157.25. Following this, you would bill G512 weekly in addition to any billable services you provide. As a reminder of what we've talked about so far, here's a summary of the codes to use when providing palliative care for a patient. We'll build this list as we go along. Several months later, you receive a call from Joseph's wife. He was scheduled to visit you in the office this week, but his wife tells you that he's now too weak to get in the car and come to the office. You arrange to see him at home later in the week. When you visit him at home, you assess the change in his status and symptoms and make appropriate changes to his care plan with he and his wife. You are in his home for 30 minutes. How will you bill for this service? When billing for palliative care home visits, it's important to remember that this applies to visits not only to the patient's private home, but also to patients residing in retirement homes and hospice residences. For palliative care home visits, there are 3 elements to the billing: billing the service and the premiums for the home visit and travel to the patient's home. The assessment code will depend on how much time you spend in the home. If the visit is 20 minutes or longer, the K023 code applies. If the visit is less than 20 minutes, use either the house call assessment code A901 or A900, the code for a complex house call as defined by the Schedule of Benefits. These would be the codes used in primary care for non-palliative care home visits. Neither of these codes has a time requirement and pay the same fee. For those practicing in a family health organization or family health network, these 2 codes are within the basket of services, but would still be codes to shadow bill. It's important to note that the home visit and travel premium codes are specific to palliative care and are listed here. The billing for this visit to Joseph's home will include the 3 elements as you see here, and comes to a total of $181.75. A few weeks later, Joseph is having more difficulty with his breathing. You are feeling unsure of the best approach to manage this and call a local palliative care physician for advice. During the conversation, she gives you advice about using opioids for dyspnea and how to titrate the dose. Can you bill for this phone call? And if so, what would you bill? When a physician requests and engages in a telephone conversation with another physician who has the expertise to provide advice about a particular patient's care, this activity is a billable service. As noted here, there are fee codes for both the referring physician and the consulting physician, and the requirements are the same for both. The minimum time for the call is 10 minutes per day, and that time does not need to be continuous. Documentation should include the start and stop times, the reasons for the consultation, and the recommendations for care. Phone conversations that are focused on a discussion about a transfer of care or a request for an in-person consultation are not eligible for this fee code. Likewise, a phone conversation that takes place on the day or the day of an in-person consultation is also not eligible. Similar to telephone consultations, a physician may reach out to a physician with expertise by electronic means. This can occur by simple email exchange or through an organized e-consult system. Again, there are corresponding codes for the referring and consulting physicians with similar documentation requirements apart from recording start and stop times. As noted here, there are maximums to the number of times this service can be billed. Similar to telephone consultations, electronic communications devoted to referrals, transfer of care, or directly adjacent to an in-person consult are not eligible. Joseph's condition is continuing to decline. His daughter, who lives in Alberta, has arrived to see her father. She's quite anxious about his condition and wants to meet with you to talk about his care. At the same time, you receive a call from Joseph's home care coordinator, who would like to arrange a conference for you and her to talk with Joseph's nurse and a hospice social worker about Joseph's care plan. How will you bill for these meetings? When a physician meets with family members to discuss the care of a terminally ill patient, this is billable as counseling. The K015 code, like K023, is billed in time units with a record of the start and stop times. The meeting must be pre-booked. In other words, a spontaneous discussion in the home or hospital does not qualify. The K015 is billed using the patient's OHIP number. For physicians working in one of the capitated patient enrollment models, a family health organization or family health network, K015 is included in a basket of services encompassed by the capitation payment, but should be shadow billed. While not specific to our case, another code to highlight is K002, the code for interviews with substitute decision makers for an incapable patient. This is also a pre-booked, time-based service. The two limitations on this code are that the interview cannot be solely to obtain a patient history, nor to obtain consent for treatment. This would be a code to use for a detailed goals of care conversation for an incapable patient. If the patient is present and alert, K023 could also be used for this type of interview. This would be of benefit for family health organization or family health network physicians, since K002 is also a code included in the basket of services and can only be shadow billed. Case conferences are billed according to the setting to which they apply. The requirements for any setting are virtual. The conference must be pre-booked and include at least 2 regulated health professionals in addition to the most responsible physician. The conference can take place in person, by phone, or video conference. As always, the conference needs to be documented. These codes are billed in units, with the units being in 10-minute increments. For any one patient, there are maximums for each conference and for a 12-month period. Note that the K700 code is within the basket of services for family health organization and family health network physicians and can only be shadow billed. As a reminder, ad hoc telephone conversations or bedside conversations with nurses, coordinators, or other healthcare providers are not eligible for these case conference codes. These conversations are part of the elements of care encompassed by the weekly palliative care case management code G512. Returning to the requests for meetings about Joseph's care, you arrange to meet with Joseph's daughter in your office and spend 30 minutes talking with her about Joseph's prognosis and care plan. The following day, you participate in a 30-minute teleconference that includes the home care coordinator, the home care nurse, and a social worker from your local hospice program. For your meeting with Joseph's daughter, you would bill 1 unit of K015 to Joseph's OHIP number for a total of $62.75. For the case conference, you would bill 3 units of K700 for a total of $94.05. Following the 2 meetings with Joseph's daughter and his care team, you decide that it would be a good idea to hold a family meeting that includes Joseph, his wife and daughter, along with members of the care team. This would be a good way to ensure that everyone has the same understanding of his condition and the plan for his care. The meeting takes place in Joseph's home and lasts 55 minutes. Because this meeting involves Joseph, the patient, it can simply be billed as a palliative care home visit. The billing for this visit would include 2 units of K023 because of the time involved, as well as the special visit and travel premiums. Before we go on to the next scenario, let's add to our summary list on this in the next slide. Several weeks later, you receive a call from Joseph's wife to tell you that he has just died at home. You make a home visit to pronounce death, complete the death certificate, and support Joseph's family. How will you bill for this service? Pronouncement of death and certification of death are separate acts, and how they are completed have an impact on billing. For billing purposes, pronouncement of death includes completion of the death certificate and support for family members who are present. The code used depends on where this occurs. In the home, A902 is billed along with the palliative care special visit and travel premiums we discussed earlier. When this occurs in hospital or long-term care, C777 or W777 are used. In these settings, if a special visit is required, the A777 code should be used along with the appropriate special visit and travel premiums for those settings. In some jurisdictions and settings, pronouncement of death is done by a registered nurse. This practice is usually an established protocol when death is expected and can occur in hospital or long-term care. In these situations, the physician completes the death certificate at a separate time and possibly in a separate location. Here, the physician will bill only for certification of death, using the code appropriate for the setting where death occurred. In long-term care, pronouncement of death is a service that is included in the monthly management fee code W010 and cannot be billed separately. We will discuss this issue in more detail a little later. For your visit to Joseph's home to pronounce death, complete the death certificate, and to spend time supporting his wife and daughter, your billing would include these codes and come to a total of $164.05. Several weeks after Joseph's death, his wife makes an appointment to see you. She wants to talk about his illness and death and wants to thank you for the care you provided for them as a family. You spend time discussing these things, but also explore how she's coping with her grief and whether there are any resources that she might need to assist her. How will you bill for this visit? Bereavement counseling is billed under the OHIP number of the individual receiving that service using the standard OHIP counseling fee codes. Bereavement counseling can be billed for an individual or for a group, as for example if a physician saw more than one family member in the same visit. Again, this is billed in units of 20 minutes with appropriate documentation of the visit and the times. For an individual, a physician can bill a maximum of 3 units of K013 annually for any patient. After 3 units, any additional units are billed as K033, with the reduced fee. For group counseling, K040 is billed when none of the group have received 3 or more units of K013 plus K040 that year. If any of the group have passed that threshold, the session is billed using K041 for all of the group. Before finishing this module, I'd like to highlight several other issues about billing for palliative care services. When providing care for patients in hospital, the usual hospital care codes apply. The one exception to that is the daily visit fee. If you are visiting a patient for purposes of providing palliative care in hospital, the C882 code should be used rather than C002. The fee for the C882 is the same as C002. However, the weekly limits on C002 don't apply to C882. While these weekly limits don't apply until a patient has been in hospital for 5 weeks, it is useful to be aware of this issue. In complex continuing care rehabilitation units, the weekly limits to daily visits occur earlier, and the W882 code should be used where appropriate. It should be noted that for physicians working in a family health organization, the C882 fee code is included in the basket of services captured by the capitation payment and can only be shadow billed. As noted earlier, when a palliative care visit in hospital meets the time criteria for K023, that code can be used for that visit. It should be noted that K023 cannot be billed in conjunction with the codes for the first, second, and last hospital days, C122, 123, and 124. The only time where one might bill K023 is when a physician spent enough time to qualify for 2 units of K023 on one of those days. In that instance, omitting the C code and billing 2 units of K023 would be appropriate. While the average prognosis for patients entering long-term care homes is relatively short, it would not be appropriate to bill palliative care fee codes for all of these patients. As discussed earlier, the tools used to guide identification of patients with palliative care needs can be helpful in deciding when to use palliative care fee codes for this patient population. It will be important to document advanced, progressive illness with evidence of significant decline. Many physicians bill for care in long-term care homes using the monthly management fee code W010. This is billed monthly and includes most palliative care services, including those that would be encompassed by the G512 code. The one service that is not included is K023, which can be used when the criteria for that code are met. If a physician decides that she or he would like to switch to using individual palliative care fee codes, that physician would need to notify their local OHIP claim office of that intent and the reasons for that. Subsequent claims would need to be submitted for manual review. Most of the fee codes used here are the same as discussed earlier, only with a W prefix. The daily visit code for a visit less than 20 minutes is W872. The exception to this recommendation would be physicians working in family health organizations or family health networks who have rostered patients in a long-term care home. Derostering patients for the purposes of billing fee-for-service is not an option. In these instances, a physician would continue to bill the monthly management fee and shadow bill for the individual services. For physicians working in family health organizations and family health networks, I've already highlighted most of the differences in billing for palliative care services. To recap, the key issues are those services included in the basket of services encompassed by the capitation payment for rostered patients. For both family health organizations and family health networks outside of the long-term care setting, most palliative care services are outside of the basket and are billed on a fee-for-service basis. Those services listed here that are within the basket are shadow billed, and a 15% premium is paid on those services. Note that there's a slight difference between the basket of services for family health organizations and family health networks. For these same physicians rostering patients in long-term care, The basket of included services is listed here. It should again be noted that K023 is outside of the basket and can still be billed on a fee-for-service basis. Again, a 15% premium is paid on shadow billed claims. As noted previously, switching over to fee-for-service billing in this situation is not likely to be possible. Finally, physicians working in these models are able to bill service for non-rostered patients. However, there are annual maximums for the total amount of billing of all codes for this patient population. In addition to the fee codes that physicians submit for payment, there is an annual bonus available to physicians who provide care services. This bonus does not require submission of a bill to OHIP. OHIP automatically captures when physicians provide one of the eligible services, have met the volume requirements, and then makes the appropriate payments. You will note that there are two levels of bonus. Level A is available to all physicians, and Level C is only available to physicians working in family health organizations and family health networks. Before we finish, on the next two slides is the completed list of the fee codes that are commonly used when providing palliative care. To review the detail for any of these fee codes, I would also recommend looking at the OHIP Schedule of Benefits. You've come to the end of this module on billing for palliative care. I hope that it has been helpful for you to become aware of the range of billing options for this patient population. I've inserted a link to the OHIP Schedule of Benefits and remind you about the OMA Guide to Palliative Care Billing on their website. Thank you for taking the time to view this module.